Thank you very much. Thank you very much for having me. Very, very nice discussion earlier. Yeah, I just want to say, in our practice, we actually send patients home, uh, do the procedure before they go home. So whether it's, there's a push now in the US, the faster, you need to get patients out faster from MI. So our average is also 3 to 4 days usually.
Yeah,
So,
several times in the already web seminar with some very famous American cataract, and then I mentioned.
right, right. No, it's very good. Anyway, so I'm gonna change topics here, and I'm gonna talk about advances in intravascular imaging and calcium modification. And these are my disclosures. And so, what we'll talk about is how calcium changes the way we do PCI. And what is calcium? We only used to worry about calcium on angiogram, and we used to manage calcium very, very differently. I think we've moved on now, and we've become sophisticated. The reason why it becomes sophisticated is because we understand calcium better than we did before. So I'm going to show, certain things. So if you look at intravascular imaging, you really need, as I say, all these things are any complex case. All the data now looks like if you do complex anatomy, if you don't do intravascular imaging, you actually do a very poor job. Across the board, you have 30 to 40% decrease in events with intravascular imaging. So I think it's a no-brainer. You need to do imaging, especially in complex cases. It's a class 1 indication, but you need to really know what you're looking at. And a lot of physicians, they want to look at how the stent looks, how this a stent touches the artery, but there are parameters for success. So it's very important to know. So if you see here, this is calcium. It's got attenuation behind it. If you see white stuff and there's no attenuation behind it, that's fibrotic plaque. So a lot of times we don't know, but we have to understand really what we're looking at. And those things make a huge difference when you do PCIs. Same thing with OCT here. You can see fibrous plaque. You can see calcium, which doesn't look like white on IVUS, but this is, the low reflectability that you see with sharp margins. The deep calcium is hard to see because OCT is limited for depth, but whatever is close to the lumen, you see it's very demarcated, and that's calcium. You can see white thrombus doesn't absorb, red thrombus absorbs, so you have a breakout behind it, and then you can see the stent. So this is what it looks like on imaging. And then when you assess calcium, you have angiography. Obviously, you can see train track calcium. It only tells you there's calcium. It really doesn't tell you what type of calcium, whether it is deep calcium, whether it is superficial calcium, or whether it's a nodule. And if it's a nodule, what kind of nodule it is. And those things actually determine really how your PCI will go. And the PCI, calcium is an enemy. 30%, at least 30% of cases that we do have moderate to severe calcification, and the outcomes are very, very poor with calcium, not because of stent thrombosis and TLR, but a lot of times you can't deliver the stents. And even if you deliver the stents, you can't expand and you can't get the minimal stent area. So those things are very, very important. So CT scan has made a big, impact in how you assess calcium. And initially you said you see calcium, you see stents, you see metal, you see blooming artifact. But now there are algorithms that actually can delineate what type of calcium you have, whether you have thick calcium, eccentric calcium, how thick it is, how long it is, and then prior to going to the cath lab, you already know what equipment you're going to choose. So it's very, very important. So OCT and IVUS, as we discussed earlier. Superficial calcium is what grows in the lumen. Deep is in the wall. We now understand that a lot of calcium has nodules. So you can see nodules, deep calcium, and superficial calcium. And the nodules also are further divided into either an eruptive nodule or a healed calcified nodule. And the prognosis is very different in those scenarios. This is very, very important for us to understand, really, and that's where imaging really comes. So this is, again, CT scan, and you guys understand, really CT is very, very important. You can see no calcium, high-grade lesions. You rotate this, you can see significant calcifications. Then you can look plaque composition. You can look at eccentricity, and it's Hausfeld units. If the Hausfeld units are greater than 130, it's usually calcium, and you can see here less lipidic, fibrotic, and then high intensity calcium that you see on CT. Correlates very nicely with IVUS findings. So you can see with virtual histology here, you can see calcium, and then you can see calcium on CT. Very, very important. So CT planning prior to PCI has actually become very, very important. Same thing here. So there are three things that are very important, which I'll show you in the next few slides. You'll see the arc of calcium. You can see across here with IVUS and with OCT and CT. Thickness. IVUS is a little limited in thickness because you have a attenuation artifact, so you really don't know how thick it is. OCT is limited in assessing deep calcium, but for superficial calcium and thickness is very good. And you can see CT actually shows you thickness in here also, and the length. So when you look at all these three things, that really determines how your artery is going to react, what modality to use, and how you can get a good outcome. So again here, the very comparison that I said, pretty much CT scan, very good with this, but not intraprocedurally, obviously. You can see angiogram is limited. OCT and IVUS are very, very similar in this scenario. So, there is no, don't have bias. I don't have bias between OCT and IVUS. Do what you are good at. Do what your hospital is equipped in doing. So, as I said, these are very, very important. So, eccentricity is important. Depth of calcium is very, very important. Thickness is important. And length is very, very important. And these are the things that they really determine how the artery is going to respond to the modalities and how you're going to get good results. So there are calcium scores, and there are OCT, IVUS scores, and OCT scores. So you can see calcium greater than 270, you get points. 360, you have a calcified nodule or your vessel diameter. You look at these kind of things. If you have higher score in this scenario, they really do not respond to balloon angioplasty. Very poor results with balloon angioplasty. Then you have to think about either you're going to do atherectomy or you're going to do lithotripsy. Okay, very important. That's IVUS score across here. Arc of calcium, depth, and length. We did not include eccentricity. It was a little older paper, but eccentricity, now that I understand nodules, eccentricity is much, much more important. OCT, you can see OCT or new deep OCT spectral wave. They actually have assessment of calcium. They give you the arc of calcium. They give you the length. They give you a thickness so that you can prepare really how you want to do the procedure. And this is calcium volume index across the same thing. Angle, arc of calcium, thickness, and length. So the rule of 5, the thickness is more than 5 millimeters. Length is 0.5 millimeters, length is 5 millimeters, and then the arc of calcium, you give scores, and the score is greater than 4, chances of you having balloon angioplasty success is very, very low. So the decision algorithm is very similar. Everybody has different algorithm, but if you see across the board, mild calcification, you do balloon or specialty balloon, and then suboptimal, you can do lithotripsy, obviously image optimization, but this repeats itself across the board. Imaging is crucial to get good outcomes in moderate to severe calcification. And then what do you do here? Again, you score, and you have nodules. So here, if it's obviously higher scores, you actually switch to using atherectomy tools, and nodules are still very poorly treated. There is no real right answer to it. If you have a good wire bias, atherectomy tools are good for it. But in general, lithotripsy has a little bit more data now with nodules. And nodules is your enemy. It's very, very hard to treat as we think we do. We expand the balloon. The balloon looks like a very nice expansion. But you know what? The balloon expands actually in the path of least resistance. It does nothing to the nodules. And that's interventionalist problem. See CT here also very similar. You can see very, very thick superficial calcium, and you see here, lithotripsy, you're having problems dealing with this stuff. So, as I said, this was just published this week. Eclipse trial was 2,000 patients, orbital atherectomy versus balloon angioplasty. Obviously, the patient subsets were different. There was no difference in the initial trial, but if you look at intravascular imaging use in calcium, you see there was a huge difference between imaging versus non-imaging. So very, very important that even in this patient subset, imaging guided calcium management is very, very important. Nodules, quick water nodules. Nodules actually happen usually at the site of torsion stress, more so in the right coronary artery and the ostium of the circumflex because of the flow dynamics, but can happen different places. But this is what happens. You have eruptive nodules, which are this is like an ACS nodule. These have thrombus and disruption and stuff. So these are very hard to treat. If you put a stent in there, they look good, but if you do 1 month later, you'll see the fronts of calcium and stuff come through the stent. So these are recurrent problems, and we really still don't have good treatment for this. This actually has been shown that if you have good bias, orbital atherectomy does well, but in general, lithotripsy actually cracks this thing so that you can get, even though eccentric, but good luminal gain, which is what you really want. And this illustrates the same thing here with nodules. And you can see here, nodules traditionally treated with rotational atherectomy have worse outcomes. But you can see with lithotripsy, you can see fractures, you can get good luminal gain, and the data actually looks good on lithotripsy because there's no difference between nodules versus non-nodules in lithotripsy, as opposed to atherectomy, they actually do very, very poor. So I'm going to show, well, I have time, I'm going to show a quick case here which actually illustrates really how imaging really has changed the way we approach calcium. So 84-year-old lady with significant history of peripheral arterial disease. She was presented to an outside hospital with ST elevations in AVL and AVR, which suggests probably left main disease. Her troponin is very high. She was taken to the cath lab and had a very bad left main. They put a balloon pump and transferred to us. And you can see the EKG, pretty bad ST elevations in AVR and ST depressions all throughout, which suggest badness. And this is what it looks like. So that's your artery. Let's see if it plays again. Okay, so that's your artery. You can see flow is compromised. It's a big chunk of calcium. And so what we did here is we tried to wire this. We were able to wire with our regular wire, but we were unable to cross a microcatheter through this lesion because it was a serpiginous calcified nodule. It won't really, we thought it was nodule, but it won't go. So what we did is we put the microcatheter in there, put a Viper wire through it, and performed orbital atherectomy, which is dangerous when you do it at the ostium, but you go forward quickly and then cut backwards, which we did. And you can see here, we get a decent channel. But then we put a balloon, and the balloon won't yield after orbital atherectomy. Why? So we looked at it. We took a shock wave and we opened it up, and it actually opened up beautifully. So we did combination therapy. The reason why is I'll show you with IVUS. Obviously, IVUS won't cross in the beginning, but you'll see. If you see here, our wire was here. We gutted this area, and we made a lumen, but we actually gutted the area that did not have calcium. And the calcium was a nodule that was on the other side. So that's when the fractures happened, with a nodule coming from the left main into that area. So orbital did something. It actually dissected and created a channel, but it did nothing to the calcium. So that's why we had to understand what was happening, why the balloon would not yield, very thick nodule, and then we were able to then open it up and protect the circ, and then we got the final result. And you can see the LED looks very, very happy right now. So pretty nice result. So I think understanding imaging, understanding different modalities, and a lot of time we do combination now. The reason we do combination is because we understand calcium, we understand nodules, we understand thick, we understand thin, we understand deep, we understand superficial. So I think we are moved on and imaging really has changed the way we treat calcium, which used to be enemy for interventionalists. So thank you very much.